All right, let's dive right into this explainer. Today, we're unraveling a fascinating diagnostic mystery that sits right at the intersection of human anatomy and the sometimes quirky physics of medical imaging. We are tracking down a phantom, a literal ghost in the machine that has tricked doctors and terrified patients for years. We know it as the IVC Pseudolipoma. Imagine the sheer panic for a second. You go in for a scan, maybe for a completely routine issue, and you're told there's a mass, a tumor, and it's sitting right inside your inferior vena cava, the main vein carrying blood from your lower body straight to your heart. I mean, it sounds like an absolute nightmare scenario. But what happens when that life-threatening tumor isn't a tumor at all? What if it's completely fake? Just a highly convincing optical illusion cranked out by a multi-million-dollar machine. And this quote right here hits the nail on the head regarding the real-world stakes of our topic today. As the medical literature points out, misinterpreting this optical illusion leads to immense psychological distress. We are talking about severe patient anxiety, totally unnecessary and often invasive follow-up testing, and a huge cascade of medical panic, all over something that is completely harmless. Section 1. What is a pseudolipoma? So globally recognized, and you'll see it noted in Turkish medical literature as VKIP, an IVC pseudolipoma isn't a tumor at all. It's actually a totally normal anatomical variant. It's simply extracaval fat sitting in the retroperitoneal space near the diaphragm that, well, because of its exact positioning, perfectly mimics a fat-containing tumor or a blood clot inside the vein. It's entirely benign. It's just sitting in a highly suspicious location. To ground us in the visual reality that radiologists face every single day, consider how an abdominal CT displays another type of pseudolipoma, this one near the Glisson capsule in the liver area. When a radiologist sees that characteristic dark, ovoid pocket of fat density exactly where it shouldn't be, alarm bells naturally start ringing. Section 2. The CT illusion explained. The real culprit causing all this trouble is something called the partial volume artifact. It's basically a glitch. When a single CT voxel, which is like a 3D pixel, encompasses tissues with widely different absorption values, the scanner gets confused. It literally can't display both distinct densities accurately at the same time, so it compromises. It generates an averaged beam attenuation.
To understand this averaging effect, think about Hounsfield units. Dense bone sits way up at around positive 800, while airy lung tissue is down around negative 800. If a voxel captures both of those simultaneously, they average out to 0, and 0 happens to be the exact density of water. The machine essentially hallucinates water onto the image, even though there's absolutely no water there.
So here is how the phantom is actually created. Step 1, you've got a normal pocket of fat sitting right above the liver's caudate lobe, snuggled right up against the inferior vena cava. Step 2, a CT voxel inadvertently captures both that outside fat and the dense, blood-filled vein. Step 3, the machine averages them together, and boom, instantly, an illusionary fat density mass appears to be floating right inside the blood vessel. Section 3, the liver disease connection. Now, in routine abdominal CT scans of the general public, this phantom tumor is super rare. We're talking appearing in only about 0.5% of all cases. For the average person, the anatomy just doesn't line up perfectly enough to create the illusion. But listen to this massive jump. The phantom tumor shows up in over 26% of patients suffering from chronic liver disease or cirrhosis. That's a huge difference. So the crucial point we need to figure out is why this ghost haunts this specific group of patients so frequently. Why does a diseased liver conjure up a fake tumor in a nearby vein? Well, here is the anatomic motive behind our ghost. Cirrhosis is essentially severe scarring of the liver, right? And as the disease progresses, the liver physically shrinks and distorts, particularly the right hepatic lobe. As it shrinks, it tugs on the surrounding structures. It actually pulls the vena cava itself, causing a structural deviation right where it passes through the diaphragm. This tug of war creates a little pocket, and surrounding fat tissue gets sucked right in, or invaginated. Suddenly, the vein and the fat are overlapping at the exact perfect angle for the CT scanner to fall for the partial volume artifact. Section 4. Solving the diagnostic mystery. So how do doctors spot the imposter? By carefully comparing the features on the scan. A true threat, like a liposarcoma, is messy. It's inhomogeneous, meaning it's not a uniform texture, and crucially, it shows contrast enhancement. Because true tumors have blood supplies, they literally light up when intravenous contrast dye is used.
Our pseudolipoma, on the other hand, it's a uniform, homogeneous, dark blob of fat that shows absolutely zero contrast enhancement. Plus, it visibly trails off and connects to the normal fat outside the vein.
To finalize the diagnosis and clear the patient, radiologists follow a specific checklist. They confirm the mass doesn't light up with dye, they make absolutely sure it's not a real tumor creeping in from the kidneys, and they look for that connection to the outside fat. But the ultimate ghost-busting tool? Thin section reconstructions. By scanning the patient in ultra-thin 1 to 1.5 millimeter slices, the radiologist physically eliminates the voxel overlap. The pixels are now simply too small to capture both the vein and the fat at the exact same time. The machine stops averaging, and the phantom vanishes instantly.
It's a powerful reminder of the intersection between human expertise and machine capability. I'll leave you with this thought. As our imaging tech becomes incredibly advanced, literally capable of seeing inside our very cells, how do we ensure that fundamental anatomical mastery remains our ultimate diagnostic tool? Thanks for joining me for this explainer, and keep questioning what you see.